Anthony. Good morning, everyone. My name's Gerard McLaughlin, and I'll be starting with the first lecture this morning on the approach to PUPD. With this slide up at the start, this is just our hospital in Glasgow, and I always like using it in our CTD talks. So the first case we're going to look at this morning is Cara, a case that presented to us in the hospital. She was a 5-year-old female neutered Labrador. The significant history that the owner presented at consultation. She reported Cara had a rapid onset obesity in the previous 2 months following ovarian hysterectomy, and actually she gained around 8 kilos 6 months previously. And the main reason for consultation was the owner was concerned about the rapid increase in thirst and urination that Cara had shown, up to 12 litres per day, which is over 200 millilitres per kilogram per day she was now consuming. So she's a single dog in one house. The owner was able to accurately measure what she was drinking, which can often be quite difficult in multi-dog households. So classically, when we think of a dog with PUPD, there's some main differentials that come to mind that we try and exclude at the start. And these would be the more common things like diabetes mellitus, renal failure, Cushing's disease. Hypercalcemia can be due to various etiologies, including parathyroid disease, but also can be neoplastic driven. Liver failure, pyogenic focus such as a pyometra, diabetes insipidus, which can be central or nephrogenic, and then the other causes such as hyperthyroidism, much more commonly in cats, Addison's disease, or psychogenic polydipsia, which is really a diagnosis of exclusion. When we exclude all medical causes of PUPD, we then have our psychogenic cause at the end. So I think what's very important when we approach these cases of PUPD is really an initial consultation with the owner to get as much relevant clinical history as possible. Often we get quite caught up in looking at numbers of the amount of water a dog will consume, and if you read various references, they'll say 50 to 100 mils can be normal, but I think in our experience what we find is that changes in water consumption are equally as important as the absolute quantities that a dog consumes. So certainly if a dog has gone from drinking 25 mils per kilo per day up to 18 mils per kilo per day, well, certainly that's still within the reference range of many textbooks, but I would consider that a significant increase in water consumption. And we have to also pay attention to dietary factors, as this dog recently changed from a wet food to a dry food, and environmental influences as well. So certainly in the winter time, then the dog may consume less water than in a warm summer day. And the polyuria, we want to look at both the frequency and volume that a dog urinates, and we have to be aware as well, in some of the cases that we see at Glasgow, often we have these older female dogs, and because they are then consuming more water, it can sort of unmask some urinary sphincter mechanism incontinence. So differentiating classic incontinence from polyuria can sometimes be tricky in these cases as well, because they often will wet their bed as well as wanting out more. Other things to consider in our patients, well, we want to obviously not just focus on the PUPD, we need to discuss the owner quite closely, the behaviour of the dog. We're looking for any signs of lethargy or episodic collapse that could show us evidence of neurological disease, endocrine disease, or cardiovascular disease. Again, the appetite of the patient is important. Is there an increase in food intake as well as water intake, or in many of the diseases that cause PUPD, such as renal failure and liver failure, we would expect our patient's appetite to be decreased because actually they're systemically unwell.
As I said, Ian will talk more about skin changes in relation to certain diseases later on, but we want to pay attention to any dermatological changes in our PUPD patients, and we're looking for signs of alopecia, often related potentially to endocrine disease or skin infections. And the other clinical signs, as with any consultation, we want to pay attention to our patients vomiting, any evidence of diarrhea, any discharges, mucopurulent discharges from the nose, mouth, vagina, or penis, and any significant medical history. I think probably what we see more in our referral side is patients who potentially had access to drugs that can cause a PUPD or previous urinary tract obstructions. So in our examination, really, we want to perform a full clinical exam on all these patients, and it's very important that we record everything accurately in our records, such as the water consumption if available, the patient's weight, respiratory rates, temperature. And in particular, attention should be paid really when I see an animal that's PUPD to the lymph nodes, Again, we're looking for evidence of paraneoplastic-driven hypercalcemia as a cause of PUPD or infection. To the skin for our dermatological diseases and endocrine diseases that can drive PUPD. For any evidence of purulent discharge, there's an animal here with some vaginal discharge, indicating a pyogenic focus or pyometra or metritis. Good abdominal palpation to detect any lymphadenopathy, splenomegaly or hepatomegaly is important. And I think people often forget the rectal examination looking for a rectal adenocarcinoma as a driving force for hypercalcemia malignancy causing PUPD. So coming back to Cara, the significant medical history we got from her owner was alongside the rapid onset of gaining weight and the massive PUPD, the owner reported her appetite was dramatically increased. She was relatively lethargic in herself. For a Labrador, she wasn't running around crazy anymore. On examination, there was some mild bilateral alopecia, and there was also a few mammary masses that we felt, and bearing in mind she was only spayed as she was an older dog, but the ultrasound was suggestive of benign lipomas. So coming back to our differential list for these top causes of PUPD, from the start, from the examination, we're probably reasonably confident just from physical exam and history and excluding renal disease, because she's a very well dog, she's got a good appetite, she's not been losing weight, and with chronic renal failure, we would expect her patients to be systemically unwell. Equally, with a pyogenic focus, she had no obvious discharge from her vulva. There was no obvious lymphadenopathy. She had no pyrexia. So again, a pyogenic focus would be much further down our list of endocrine disorders causing PUPD. And classical Addison's disease, again, she's a very well dog. She's not got the typical bradycardia or collapse that we would associate with an Addisonian crisis. So again, we would probably move that much further down our list of differentials. So this shows really just from a good physical exam and history, you're able to already start to exclude some of the more common causes of an increased thirst and urination. So at this point, really, we start thinking about, okay, well, how are we going to launch our further investigations? And usually what I start with is a very straightforward urinalysis from retained bacterial cultures if thought appropriate. In Cara's case, the urine examination, sediment examination, and dipstick was completely unremarkable. We didn't find anything, no obvious evidence of hematuria or pyuria or bacteriuria. And her urine-specific gravity, very, very hyposthenuric at 1.002. It's worth bearing in mind, obviously, it's worth sometimes asking owners to collect multiple urine samples to check the urine-specific gravity at various times in dogs, because even in a normal dog, the urine-specific gravity can vary quite markedly throughout a 24-hour period. So Cara had a USG of 1.002, and that was fairly repeatable in her case, which obviously indicates she has quite marked hyposthenuria. I think coming back to just looking at urine-specific gravity, we have to bear in mind that when we have isosthenuria, which is a USG between 10.08 and 10.012, then that starts to indicate that we've got a loss of nephric function, so an animal who's unable to concentrate or dilute their urine, and that's very concerning because that obviously indicates some degree of intrinsic renal failure. So 10.08 to 10.012 starts to raise alarms of intrinsic renal disease. Whereas if we have hyposthenuria, we start thinking of diseases that potentially are helping us or causing loss of ADH or its receptors, such as primary or central diabetes insipidus, or in something that's antagonizing ADH. And this is really a lot of other causes of PUPD, such as Cushing's disease or hypercalcemia. All of these diseases will antagonize the effect of ADH on the collecting duct. So I think we have to bear in mind that the low specific gravity seen in Cara's case doesn't automatically mean that she has diabetes insipidus. It can mean that she's got another disease, such as Cushing's disease, that's preventing the ADH from working properly. And obviously in dogs that are on IV fluids or having excess water in consumption or diuretics, we can often expect a very low USG as well. So I think all we can say from this point is it's very unlikely, again, we take this from her history too, that she has a degree of renal failure. On the urine-specific analysis, as we said, there was no glucose, which helps us exclude diabetes mellitus from our list of PUPD causes. Ketones were unremarkable, but obviously in any patient they can be a significant finding. And in Cara's case, there was no protein, blood, and sediment examination was